A big hello and welcome to everyone joining us today for yet another edition of Cancer Research Institute's Cancer Immunotherapy and You Patient Education Webinar Series. I'm your host, Dr. Ajit Mule, and it is my great privilege and honor to welcome you to this live webinar event, which is part of our month-long Cancer Immunotherapy Month. The topic for today's discussion is Pancreatic Cancer Demystified, Expert Insights and Breakthroughs. Today, we are joined by a truly distinguished guest, a world-renowned cancer immunologist, and one who is transforming the cancer treatment landscape for pancreatic cancer. Please welcome Dr. Robert Vonderheide from Abramson Cancer Center at the University of Pennsylvania. Dr. Vonderheide is the leading figure in the field of cancer immunotherapy and oncology. He is the director of Abramson Cancer Center and vice dean of the cancer programs at Perelman School of Medicine. He is also vice president of cancer programs at the University of Pennsylvania Health Systems. Welcome, Dr. Vonderheide. It's great to have you here with us today.
Thanks very much and welcome everybody.
Thank you so much, sir. And without further ado, I would like to jump right in. And just to let our audience know, can you just tell us what is pancreatic cancer and are there different types of pancreatic cancers?
Pancreas cancer, pancreatic cancer are tumors that arise from the pancreas tissue itself. This can be a little interesting because there are different tissues within what we call the pancreas. What is generally referred to in the far most common type of pancreatic cancer is a carcinoma that comes from the part of the pancreas that are the cells that help digest food. There is a rare form of sort of a neuroendocrine form of pancreatic cancer that also exists. When we hear about pancreatic cancer that is growing in incidence and we hear about it on the news, generally speaking, it is pancreatic carcinoma. Unlike some tissues, we rarely see other types of cancer going to the pancreas as a metastasis. So usually when we see a mass or something suspicious in the pancreas, we think of a primary origin pancreatic cancer.
What are the common symptoms that you see for pancreatic cancer?
It can vary, and people can get quite sick, as we know, but in the early stages, the symptoms can be really subtle. And it's, as we're going to talk about today, hard to pick up just by a patient's symptoms. You know, very often patients I meet will have had fatigue only as a symptom, or just not feeling right, or some vague pain in their stomach. Oh, that must be nothing. It can, however, there can be symptoms where if the tumor is blocking a bile duct, for example, jaundice can develop, and the color of the skin and the whites of the eyes can change very dramatically. So and there can be associated other phenomenon like infections or blood clots that can make when a person's diagnosed very dramatic. But in the early stages, one of the problems is the symptoms can be quite subtle.
With these complicated symptoms, I'm sure diagnosing pancreatic cancer is very difficult. So how do we go about diagnosing them in clinic?
Once a patient and their provider is suspicious of a symptom or perhaps they're even being screened for pancreatic cancer, imaging is how we get our first clue. Again, if you see something, a new mass in the pancreas, we think first that this may be a primary pancreatic lesion. We see cysts in the clinic. We can usually tell them different from an actual growing invasive tumor. As is always the case, or nearly always the case in oncology, we need to get a sample of the tissue and look at it under the microscope to know for sure. And that generally involves a procedure, at least the way we do it at the moment. So typically, if we're suspicious about these symptoms, imaging reveals a mass, and then that leads to a procedure where we get a biopsy and make the diagnosis as pathology. That's actually not complicated. We know how to do it. Making the diagnosis of pancreatic cancer is relatively straightforward, but prompting those studies to make that diagnosis is where we often find in half of the cases when we diagnose a patient with pancreatic cancer, it's already spread to beyond the pancreas. We really need to work for diagnosing earlier, where we have a much better chance of a better outcome for the patient.
So, are there challenges to diagnose the pancreatic cancer at early stage? Because I know diagnosing early for any type of cancer is basically our best foot forward. So what kind of challenges are there for diagnosing pancreatic cancer at an early stage?
The main challenge is meeting a patient when they're at an early stage and doing these tests that we find the cancer at an early stage. We're learning that is possible by aggressive screening in patients at high risk. You can find an earlier lesion. Why is that important? We want to find pancreas cancer at its earliest stage, stage 1, because we want to be able to take the patient to the operating room and resect it. It's at that situation when we can talk to the patient about being cured of pancreatic cancer. If it's local and small and we can remove it. It becomes much more challenging if it's spread, or certainly spread beyond the pancreas. As I mentioned before, about half of patients, according to the American Cancer Society, who are diagnosed with pancreas cancer have distant pancreatic cancer at the time they're diagnosed. Maybe next to ovarian cancer patients, that is the highest percentage of diagnoses that we make in the advanced distant realm. There's a great deal of priority to be able to diagnose patients earlier. It's just hard because symptoms can be very subtle or none at all for years. And it's hard to say for a patient who has no other reason to suspect that, that vague abdominal pain, that might be pancreatic cancer. It's very tricky. We need better ways of prompting these tests that will allow us to make earlier diagnoses.
We were talking about high-risk patients. So are there any risk factors that we should be aware of when it comes to pancreatic cancer?
Yes, there are lifestyle issues. We see associations with a history of smoking. We see associations with obesity. We know that family history is important. And in many cases, family history is on the basis of an inherited genetic mutation, which we're learning about more and more. A very commonly seen one in our clinic is germline mutations in BRCA1 or BRCA2. Those are very important risk factors because we can, long before a patient is a patient, we can understand if they have inherited those mutations and are at risk for pancreatic cancer, along with the other tumors in the spectrum of BRCA1 and 2 mutations. But there are other mutations, PALB2. There's several, and several. There's a collection that can be measured on a patient who has a family history, and so that we know well in advance that the patient is at much higher risk than the general population. And we're trying to learn now if those are now the individuals that we say, okay, let's do aggressive screening. And we're in the middle of some very in-depth studies. Some of the early data has been reported where we're learning to the extent we can identify such patients and screen them and find these cancers early. A lot of work in this area, a lot of unknowns still, but certainly a lot of hope and progress on that. The good thing about understanding your genetics is that it's a very simple test. It can be a blood test, but it can also be a saliva test. There's no needles involved. Information is power, and patients who have a family history or those who are at risk for some other reason, to understand their risk ahead of time is super important.
How do we treat pancreatic cancers? Like, is there a set regime that we are following now?
Well, let's just take a step back. So it completely depends on the stage and of the cancer that's diagnosed. So like I said, if it's local, we look for opportunities to resect that cancer. And there the outcomes still not even close to where we want to be. But very often we can offer the patient, the opportunity to talk about being cured of pancreatic cancer. We should be clear with patients that this is what our goal is. And one of the most important things to understand when we meet a patient is, can we straight away resect the cancer or not? It's in a very tricky area. There's major blood vessels. There's other reasons where the operations can be quite intense. And in general, these surgeries are best performed at a center that has great experience with high complexity pancreatic surgery by a surgeon who has experience. So not just experience, but the judgment to understand, is this the right time to resect? what we've learned increasingly over the last few years is that there are cases where we do not take the patient straight to the operating room, but we treat with other therapies beforehand. And these can include chemotherapy, but there's other situations where we also use radiotherapy. And I think that pre-surgical treatment of patients with local pancreas cancer is a growing field. I think we're going to see major headway. We know that this is promising. We've seen this true in really transforming the treatment of patients with local breast cancer, bladder cancer, esophageal cancer, where lung cancer, again and again, where we're learning that we flip the traditional way of treating a patient, some treatment first, followed by surgery, and then possibly treatment afterwards. So we're at that point now in patients with pancreas cancer. So that's if a patient has a tumor that's localized, and there's an opportunity to resect. Sometimes those pre-surgical treatments create the opportunity for a resection, and there's just great excitement about what is possible. Now, unfortunately, as I mentioned, a large percentage of patients that we meet already have distant metastases, and their surgery is not obviously the first option, and we give systemic therapy. Over the last 10 years, the largest advance has been identifying the use of combination chemotherapy. And we've seen changes, small but important and significant changes in the overall survival of all patients diagnosed with pancreas cancer, I think largely on our ability to deliver combination chemotherapy with great skill and lower and lower side effects. This was possibly not really available to us more than 10 years ago. And we're seeing the ability of rapidly deployed combination chemotherapy to halt the disease, make patients feel better right away, and allows us to think about more options. So for advanced disease, combination chemotherapy has been the mainstay. Now, what we're learning is that not every pancreatic cancer is the same, and they come with different mutations. And this is really an exciting area. For example, the very tumors that are on the basis of those mutations in BRCA1 and 2 can be treated with additional therapies, sometimes given after the initial chemotherapy is given. And these are PARP inhibitors. These are pills that are being used across oncology, but have an indication in patients with pancreatic cancer, but just the subset of tumors that have that particular mutation. So we're really stepping into the field where we don't want to treat every patient with advanced pancreatic cancer the same. And you may not give all the therapy at the same time. There may be a sequence, and we can talk more about this. There are opportunities in certain patients even with advanced disease who have a particular mutation or particular type of pancreatic cancer. One example is MSI high, where immunotherapy is actually indicated and can have effects in patients with that type of tumor, whereas the other patients with pancreas cancer don't respond to that type of immune therapy. Now, that's just a small percentage of patients, 1%. But what we're starting to understand is that there's a percent of patients that have this type of pancreas cancer, and 5% who have this, and 10% who have that, which means that we now need to look at a patient and say, well, what kind of pancreas cancer do you have, and how can we tailor the therapy for them? And what is fast on our doorstep, it's not here yet, but it's coming, are new drugs that block the most common driving mutation, not inherited, but develops in the tumor, against KRAS, the KRAS mutation, which we've long understood to be a driver of most pancreas cancers, but we haven't been able to treat it. But now, for the first time, we have these opportunities, new drugs, some of which have been FDA approved. There's been recent approvals even in the last few days. In pancreas cancer, we're really waiting still for that opportunity. And we can talk more about this. But again, this will be a situation where we will say, okay, do you have a KRAS mutation in your tumor, and what type? So we'll be able to build on what we know about surgery, what we know about radiotherapy, what we know about combination chemotherapy to bring in these targeted therapies. It's one of the most exciting moments now, I think, for the opportunities to treat patients with pancreas cancer. The This has been a very tough disease. Many people listening understand that personally, understand that for their family, and certainly all of us providers know this. But this is really a moment where we're seeing advances coming very fast. We hope for great things for the future.
What we are hearing is pancreatic cancer. We cannot put all pancreatic cancer into one bucket. These are like different type of cancers based on their mutational profile, based on what stage we are diagnosing the patient. And that can be really challenging for patients. So with the advancements, and specifically, I wanted to touch about the immunotherapy. What are the latest immunotherapy advances that you see in clinic or in some of the clinical trials that you are part of?
This is really an important topic, and obviously CRI has been a field leader in driving new thoughts around immunotherapy across all types of cancer. I did want to point out our partnership with the Lustgarten Foundation, as well as BMS, and some of the work that we've personally done looking for new immune therapies for pancreas cancer. So here's what we know in 2024. There has been many breakthroughs in immune therapy for all sorts of cancers. There have been antibodies developed called checkpoint antibodies. Many of your viewers will know what I mean. Unfortunately, very unfortunately, the utility of those antibodies for patients with pancreas cancer, with rare exceptions, including one I mentioned earlier, have been very, very disappointing. And we think they might be part of the armamentarium in combination, but by themselves, they are disappointing. And so we've really had to open our minds to other opportunities. One of the issues is, for reasons that are biologically quite interesting, pancreas cancers, they don't tend to provoke a strong immune response in the first place. They sort of hide from the immune system, and there's molecular reasons and cellular reasons that we're uncovering daily as to why that's the case. Every one of those mechanisms is an opportunity to find a new therapy where we could derail these mechanisms that pancreas cancers use to hide from the immune system and therefore expose them. If we can do that, we really think that some of these other therapies that I mentioned just a few minutes ago might actually begin to work. And there's growing evidence in early clinical trials where this is the case. There have been many attempts to develop cancer vaccines for patients with pancreas cancer, and some of them have been quite interesting. There have been patients who've done quite well, but reliably, we know they're not reliable enough. We know we need to do better. Many of those studies have enrolled patients who have already completed chemotherapy for advanced disease. They've already been through some other experimental therapies. They are not feeling well. Their immune systems have been beaten up by both the chemotherapy and the disease itself, and the vaccines have had really, really great difficulty. A breakthrough that's happened over the last year or so has been to bring cancer vaccines, and we can talk about what they are, to patients much earlier in their trajectory. And in fact, one opportunity that's been really exciting has been to deliver vaccines for patients who've actually undergone surgical resection. So now we're talking about those patients we mentioned earlier. They've been diagnosed, they have an opportunity for surgery. We follow up surgery often with other types of chemotherapy, and we complete that course. We know that those patients are still at risk for relapse, and in fact, high risk for relapse. It's that opportunity where we've seen vaccines be applied. These are now more healthy patients. Their tumor has been resected. They are not getting ongoing treatments with chemotherapy. And there's been a number of modalities where patients are then vaccinated with the notion of trying to generate an immune response. I mean, and there have been several formulations. And by formulations, I mean, how is the vaccine actually manufactured and made? This is where we're really partnering with bioengineers and borrowing from other elements of medicine. I'll give you an example. So we learned how the power of vaccines generated with messenger RNA and lipid nanoparticles from COVID. Those vaccines always were thought to potentially have a cancer application, but when COVID came, we suddenly saw how they could work. Investigators and worldwide effort has actually brought such mRNA vaccines forward. Completely, experimental. These are not FDA approved, and the vaccine is using mRNA technology. and to deliver elements of the patient's own pancreas cancer, those mutations, to try to get an immune response against an individual's patient tumor mutations. So it's highly personal. And the results are quite interesting. I was privileged to hear an update on the results about a month and a half ago, and it's really exciting, and it's gone on, to my knowledge, to a randomized national study. Pretty exciting in the field, and that's not the only example. There have been other vaccines, not on a per person basis, but vaccines targeting the KRAS oncogene, what I mentioned before, which is often found in patients with pancreas cancer. And again, the ability to generate an immune response is being shown. There have been very early results of what appears to be benefit for patients, not proven, needs more study, but this just goes to show you how rapidly the field is advancing, because if you go back a year, certainly 2 years ago, none of this had come out yet. This is all new.
Sure, no, definitely. This is really interesting time for cancer treatment. And I just wanted to ask you to elaborate a little bit on the cancer vaccines and the precision nature of it. Like, are we looking at, like you talk about patients who have already undergone surgery for their pancreatic cancer? So the vaccines are developed for the specific cancer, pancreatic cancer that the patient has, or it's like a broader vaccine that we're talking of?
Well, there's both, actually. There's good emerging data for both types, and there's actually multiple efforts. There's some, as you said, these investigators look at the tumor that the patient has that is obtained at resection, and then the vaccine is crafted just for that patient, right? It would work on Mrs. Jones, but it wouldn't work on Mr. Smith.
Mm-hmm.
So that's advancing, as I mentioned. Then there's others that say no, it's based on the particular KRAS mutation, and that can be patient specific, but they are more commonly shared across multiple patients. So there's more of a chance to have off-the-shelf approach. Now, I'd offer one other very exciting thing that's happening as well, which is can we develop vaccines in the prevention setting?
Mm-hmm.
And this is something that we've been working on with the Cancer Center here at Penn and other foundations. There's other investigators looking at how to do this in high-risk patients. But the notion is, can we meet an individual who doesn't have cancer, but we think is at high risk? We talked about some of the reasons earlier in the webinar. And instead of just doing screening, which is going to be important, can we actually intervene to try to intercept the tumor? And those vaccines are not based on the patient's tumor, of course, because the patient isn't a patient yet. But there's other ways to do it, and we've had some strategies targeting enzymes like telomerase, or you can even go after the KRAS oncogene and other approaches where we try to generate an immune response against a patient's tumor in a prevention setting. They're not patients, they're healthy individuals. In fact, with the support of the Cancer Center, we're actually vaccinating healthy individuals who have germline mutations in BRCA1 with our prototype vaccine to begin this journey of developing a truly prevention vaccine for individuals with germline BRCA1 and 2 mutations who are at risk for pancreas and other cancers.
I would like to take a few questions from our audience, and we see quite a lot of them coming in. One of the questions is about using Fibrinogen antibody for treating pancreatic cancer. If you can say something about that.
You know, there is a larger point in those types of approaches, which is that one of the reasons I mentioned pancreas cancer hides.
Yeah.
It hides within connective tissue.
Mm-hmm.
And so are there ways of destroying the connective tissue? And the connective tissue, it makes it hide from the immune system, but it also makes it hard to deliver drugs, these things that have otherwise great power. And that may be one of the reasons patients are resistant to certain therapies. So there's a great number of efforts, and this may be one of them, where we're trying to destroy the stroma or the connective tissue.
Yeah.
In other words, turn those tumors into more like Swiss cheese so that other approaches, other drugs can get in. And also, it's a bit like if you have a brick wall and that's the
Mhm.
pancreas cancer, you could try to attack the bricks and, you can only get so far. But if you can melt the mortar between the bricks, then it's a weak wall and you can push it over. There's any number of approaches like that are really cool. So we hope that they come forward.
That's a fantastic analogy, sir. The brick and the mortar thing. That's amazing. You talked about a little bit about the radiation therapy, and we have one question about radiation therapy for pancreatic cancer. I mean, are there radiation therapy that are available by themselves, or they are given in conjunction with the therapies or the surgeries that we were talking about?
Good to circle back on that. So among the multidisciplinary team, critical members include our radiation oncologists.
Mhm.
And there's great utility for radiation therapy for patients with pancreatic cancer. Certainly, in a palliative setting, but also in a curative setting, right? And we're trying to learn exactly how and when. And how is quite interesting in terms of, can we take advantage of new technologies in radiation therapy? I mean, what we do today and how we deliver radiation therapy compared to even 10 years ago, even 5 years ago, is dramatically different. There are now not just photons, there are protons.
Mhm.
There are now stereotactically delivered, highly precise, localized ways to deliver, and on and on. The physics that's being developed is amazing. So in the past, when we've used radiotherapy, some studies have shown, yes, it's really beneficial. Some have questioned that. What I would suggest is that there's great opportunity for these new technologies to bring radiation therapy forward and to understand exactly the same challenge we have with how to use chemotherapy. So, and there could be an opportunity to use radiation therapy to convert a patient who isn't, along with other therapies, who isn't ready for surgery yet, but could be. If you could see behind the curtain for when a patient is diagnosed, the vast number of disciplines, physicians with disciplines and nurses and genetic counselors who come to study and understand how we're going to treat this particular patient, it is amazing. And everyone brings their new technologies. And when we get an idea that sounds like, hey, this is really a good one, then we together craft a clinical trial. And that's how we're going to learn. And that's what CRI has been so amazing, and Lustgarten has been so amazing at supporting our efforts for clinical trial investigations.
Thank you so much, sir. One more question I have is how, like we were talking about combination therapies using chemotherapy along with other conjunction therapies. Is there a possibility, and do you see that an option for patients where we use radiation therapy along with immunotherapy as well?
That's commonly done.
Mhm.
Like all things, not without controversy, but commonly done. We're constantly trying to learn the best way to do it. Can I make one other point about combination therapy? And this is really emerging data, and in fact, in partnership with Lustgarten, this has really been something that we're thinking about. So we have a number of tools now. So we could do immunotherapy, targeted therapy, chemotherapy, other things we've talked about today, vaccines. Do we deliver them all at once? Or do we, in a more strategic way, understand how to sequence this?
Mhm.
So, for example, we've learned the great power now in certain patients of delivering, who have advanced disease, chemotherapy right away without delay, and then stopping the chemotherapy and switching to a targeted therapy like a PARP inhibitor or potentially an immune therapy. I think we should, and the field is beginning to look at combinations, not just as a whole bunch at one time, but taking advantage of sequencing. This is really where we're starting to see some major breakthroughs.
Sir, I see another question coming from one of our viewers. He is interested in understanding if the scheme of making cancer vaccines, if that works for all cancers in general, or can a vaccine be tailored specifically for pancreatic cancer?
Yeah, so all of the above. So one of the interesting things about the mRNA vaccine, which is based on that particular patient's tumor, a very similar strategy by a whole other group is being advanced for patients with melanoma. And we're beginning to see, again, in the setting after initial surgery, in combination with other immunotherapies, we're beginning to see a pattern of how to gain success. There really, in my view, is no reason to think that if we can advance patient-specific mutation-based mRNA vaccines for patients with pancreas and melanoma, that we won't see such efficacy in other tumor types. There's great hope there. So I think one point to the person's question is yes, there's great applicability to this approach. We talked about KRAS vaccines. Well, there are other tumors driven by KRAS oncogene, certain lung cancers, colorectal cancers, many others actually. So these vaccines, which are a little more off the shelf, and those mutations can be shared, across multiple patients. You can imagine vaccines that we're learning about against KRAS in patients with pancreas cancer, they can have great applicability to patients with other types. This is part of our work in oncology to break out of our disease-specific thinking, where we understand there are generalizable vulnerabilities of cancer that similar approaches can be relevant for many, many patients. In fact, that's why we're seeing success in cancer treatment these days.
I have time for just one more question, which is again coming from one of our viewers. He wants to ask if there are any blood tests that are specific for pancreatic cancer for people who have strong family history. So I suppose this is somebody healthy who is not who does not have pancreatic cancer, but maybe at high risk because of the family history. So are there any blood tests or genetic tests that they can have a look at?
So early detection, again, is a very important goal. And, there are now developed blood tests where we can look in great depth at mutated DNA that's in the bloodstream. This is all over the press. You can read all about it. It's controversial. There's in early days. We have learned that you can detect the mutation in KRAS in the bloodstream with great precision. That's one example. And yes, we might be able to very early on detect patients with low-stage pancreas cancers by such tests. I think there's great hope there. I think we should recognize that there is a lot of work to do to refine that. It's pretty exciting that there are still some issues and limitations in that. There are a lot of clinical trials in this area, and I would really encourage folks who are in the situation you said to join a clinical study so we can figure this out.
Thank you so much, sir. This has been a really intriguing conversation. I want to thank you for your insights into immunotherapy, in cancer vaccines, in pancreatic cancer, and such a lovely discussion, sir. I'm sure the viewers are going from here are more aware of the treatment options that they have and the latest development that we are talking about in pancreatic cancer. I want to say this personally as well, sir. Your work has brought immense hope for all the patients out there. Thank you so much for being with us today.
Thank you, Ajit, and on behalf of everyone here at Penn Medicine, thanks to CRI for being such a great partner, not only for us, but for patients all across the world.
Thank you so much, sir. I also want to thank all the viewers who have joined us today, all the questions, the participation. These conversations bring out the best of these discussions. And also, if you want to learn more about immunotherapy, and if you want to watch more of this kind of informational content, please visit the Cancer Research Institute's website. I want to also give a special thank to all our sponsors, Bristol Myers Squibb and Lush Garden Foundation, for supporting this webinar series. And I wish you all a wonderful day. Thank you so much and stay safe.